Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, and we are streaming live from the Moses Lake Professional Pharmacy podcast studio. And we are really excited to have Dr. Jenn Simmons on our podcast today to talk all about breast cancer. Dr. Simmons, welcome to our show.
Thank you. I'm so happy to be here.
Yeah, so thank you so much. It's an honor and a privilege to have you on. Um, I've got so many questions for you, so I'm going to be looking at my phone while we ask questions. But
Fair enough.
first of all, I want you to introduce yourself, your background, and how you came into this space on breast cancer.
Yeah. So, I'm Dr. Jenn Simmons. I am a breast cancer surgeon turned functional medicine doctor, integrative oncologist, and I am on a mission to forever change how we diagnose, how we treat, and how we screen for breast cancer. I come into the breast cancer world very organically. I come from a breast cancer family. I actually don't remember a time in my life where I didn't know about breast cancer. It's absolutely part of the fabric, the thread of my family. And growing up, I had a first cousin. Her name was Linda Creed. She was a singer-songwriter in the 1970s and 1980s. She wrote all the music for the Spinners and the Stylistics. I am severely dating myself right now. And she wrote 54 hits in all, but her most famous song was The Greatest Love of All. So she wrote that song in 1977 as the title track to the movie The Greatest, starring Muhammad Ali, but it really received its acclaim in March of 1986 when Whitney Houston would release that song to the world. And at that time, it would spend 14 weeks at the top of the charts. Only my cousin would never know because she died of metastatic breast cancer just 1 month after Whitney released that song. I was 16 years old and my hero died. Her life and ultimately her death gave birth to my life's purpose because I never wanted another woman, another family, another community to have to suffer the way that mine suffered. And so I did the only thing I knew how to do. I became a doctor, the first doctor in my family. I became a surgeon. I became the first fellowship-trained breast surgeon in Philadelphia, the first oncoplastic surgeon in Pennsylvania. And I did that really well and for a really long time. And I did it long enough for my aunt to be diagnosed and long enough for my mother. And at 46, it was my turn to hear those words. And I was sitting in the office of my friend and colleague and physician, and he told me that I needed surgery and chemo and radiation and things that I said all day, every day, without hesitation or reservation. And yet, when these words are coming at you, I assure you, they have a different impact. And despite the fact that I knew what he was telling me was the right answer and standard of care, I could not quiet this voice in my head that said, there's something more, go find it. Now, I do not come from an integrative medicine background. I don't come from that kind of family. I had no idea that there was another choice other than conventional medicine. And at the time that I was diagnosed with thyroid, I did not I was running a cancer program for the hospital. There was nothing about me that would have even considered an alternative, but I couldn't quiet this voice. And it led me on this journey to arrive where I am today. And it was initially a journey fraught with lots and lots of obstacles and barricades, and it was treacherous, and it took me years to study functional medicine, to learn, to figure out how the body works and how to heal the body. But I did it. And once I did that for me, I couldn't remain in integrity if I wasn't going to do that for everyone else. And so in 2019, I walked away from conventional medicine and I opened up Real Health MD, which is a functional medicine practice for women anywhere along the breast cancer spectrum, whether they are just getting diagnosed or they're in treatment or they've completed treatment and they're wondering now what, or they're living with metastatic disease or they're previvors. I'm helping all of these women to claim their health And in addition, this new place and this new practice started me asking questions that I never asked before, like, is the way that we're screening for breast cancer correct? And the answer was a resounding no. And I have spent many years diving down into the data, and it just does not support what we're doing. And many, many women and practitioners believe that they're doing the right thing using our current system to screen for breast cancer, when in fact they are just, unfortunately, pawns in the game. And what we're doing right now is creating way more problems than it's solving, and creating way more disease than needs to be, and mostly creating diagnoses for women that don't need them.
Wow, there's a lot to unpack right there. So I do have to clear one thing up. I get confused pretty easy. My wife has to constantly tell me in movies who's doing what. So you did have breast cancer or thyroid cancer?
I had thyroid cancer.
Thyroid cancer. Okay, I did want to clear that up. And so one of the most, probably the reason I found you on Instagram, and probably the reason I found you was, you say some controversial stuff like you just said, and mostly about mammograms. You didn't say it, but mammograms. You don't believe in mammograms. Is that correct?
That's correct. Well, I don't believe in screening mammograms. And not that I don't believe they exist. Surely I know that. But I don't believe in using them for screening. And, this isn't just me or my opinion, or this is looking at the data and knowing with 100% certainty that there has never been a study that showed that using mammogram to screen increases overall survival.
Wow.
That data doesn't exist. It simply doesn't exist. And for all the people that are walking around believing that mammograms save lives, it's simply not true. And when we look at the landscape of what mammograms actually do, mammograms actually end up costing lives. And they do it in a way that no one, patients included, realizes that that's why it happened and how it started. But when we look at the original data, the reason that every country in the world started the mammographic screening program was because of an invitation to screen study that was done in the UK in the late 60s. And the mammographic screening program that started in the United Kingdom was started by a surgeon, Dr. Michael Baum. And he did it based on the results of this invitation to screen study, which gave certain women an invitation to screen. So already there's bias, because who are you giving invitations to screen to? People who are monitoring their health, because the ones that aren't are not getting that invitation. And there's selection bias beyond that, because it's not like everyone who got an invitation to screened. But beyond looking at that, even if we ignore all of the bias that existed in that study, what the study results were, it looked at 1,000 women over 10 years. And if you screen 1,000 women over 10 years and compare them to even age-matched controls, if you screen with mammogram, 4 out of that 1,000 women will die of breast cancer. If you don't screen with mammogram, 5 out of that 1,000 women will die of breast cancer. And 4 is 20% less than 5. Therefore, the study concluded that mammogram decreases your risk of dying of breast cancer by 20%. Okay? That is the foundation with which every single mammographic screening program in the world is built on. Okay? Now, what they didn't report And what they chose to not report is that when you looked at those two groups of 1,000 women, the same number of women died of cancer in both studies. There was no difference. So mammogram does not prevent you from dying of cancer. And for every 1,000 women that you screen, at least 100 will get called back for additional views, a biopsy, and going beyond that, when you compare in that 1,000 women, there will be an additional somewhere between 20 to 30% of them that will be unnecessarily diagnosed with breast cancer. And so when you take those studies further and you look at the Swedish trials, when you look at the Canadian breast cancer screening studies, and these are huge studies, 600,000 women in the Swedish trials, 90,000 women in the Canadian breast cancer screening study. When you look at these trials, and these aren't invitation to screen studies, these are randomized prospective studies with absolutely age-matched controls and comorbidity controls. When you look at these, the same number of women die of breast cancer, whether you screen with mammogram or not. And the only difference between the groups is that if you use mammogram to screen, you're going to pick up a percentage of the population that is asymptomatic, right? They have no symptoms. They wouldn't know but for the mammogram that they have any disease. Well, that number is 20 to 30% more cancers diagnosed in the population that screens as compared to the population that doesn't. But the number of women that die of breast cancer in both groups is exactly the same. In both studies, exactly the same. So we're not saving lives. We are not saving lives. Now, part of the beliefs of the value of mammogram is that it's going to save lives because we're going to catch the breast cancer earlier, detect it earlier. People will have less treatment, have less aggressive disease, have less advanced disease, and therefore save lives. So that is not true. And the reason it's not true is because breast cancer is not a linear disease. It's not something that starts really small and then gets a little bigger and then becomes invasive and then becomes lymph node positive and then becomes metastatic. It does not follow that linear, predictable progression. So breast cancer is what it is from the very beginning. And it doesn't matter if you find it when it's 1 cell, 1 million cells, 10 billion cells. It's going to behave the same no matter what. So finding it early doesn't matter. And we know that because no matter how many mammograms we do every year, the exact same number of women die of breast cancer. No matter how many mammograms we do every year, the exact same number of women present with advanced disease. We are not changing the bottom line. We're not impacting the bottom line at all. So we know that mammograms are not saving lives. But what if they're saving breasts? Because what if the second part of that promise that will save lives and will detect things earlier and people will have less treatment? If it saved breasts, that's a worthwhile endeavor, right? Mm-hmm. That's a worthy cause. So let's go to the data. What happened to the mastectomy rate when we increased screening? Well, it increased.
Of course.
In a linear progression that mimics the number of mammograms we do. So as we do more mammograms and make more diagnoses, so too do the number of mastectomies rise. And in fact, the mastectomy rate rose by 20%. So we're not saving lives and not saving breasts. And this is Dr. Michael Baum's greatest regret in life, is that he was the one who basically curated the worldwide mammographic screening program. And it's his greatest regret in life.
Wow. Janet, I bet you have lots of
Oh, I
questions.
have a lot
I
to
do.
unpack. I don't have enough time. I guess the thing is that so many women get the diagnosis and then they do all of the treatments that are recommended. And, I can't tell you countless of friends that I've talked to, and it's like, how to decide what treatment you should accept or what you should do, because the hard part about this is it's so scary for people.
It
And
is.
then if they choose to do something other than what their oncologist is telling them, they're just frightened beyond belief that nobody is going to take care of them, that they're going to be kicked to the streets. And, I mean, I probably hear this quite often throughout the year about, well, if I don't do this, then therefore I won't get anybody to take care of me. So what
So
do
it's a legitimate concern, right? And there are many conventional medical oncologists who will, in fact, not take care of you if you're not following standardized treatment. And it's partially why I wrote my book, The Smart Woman's Guide to Breast Cancer, because women are put in this horrible position. They are terrified, right? And they are being forced, essentially, to make these enormous decisions in a very short period of time, right? They want to get you on the schedule next week for your surgery, or start chemo next week, or you just finished surgery, but you need to have radiation right away. And they're forcing these decisions on these women when they're not in a position to even decide what they're having for dinner, let alone what they're going to do in terms of treating their breast cancer. And they're not giving them the facts in order to make these decisions with. So these women are forced to make these decisions in a very uneducated way. So the first thing I say to everyone is that even though your breast cancer feels like an emergency, it is not.
Right.
It is not an emergency. With very rare exception, I can tell you what the 3 exceptions are. If you have inflammatory breast cancer, and that's one of those things, like if you have it, like big normal breast one day, big red swollen breast with skin puckering and a big mass the next. Like, it's a very rapidly progressive disease. If you have metastatic disease to your bone causing a fracture, not just metastatic disease to the bone, that is not an emergency. But if you have a fracture from metastatic disease, these are very painful, and it's nearly impossible for you to heal while you're in pain. So that is something that needs rapid and fairly immediate treatment. And then the third thing is if you have brain metastasis, because the skull where your brain is housed is a fixed space. There's not a lot of room for expansion there, and metastasis causes a lot of swelling, edema, that kind of thing. So you definitely don't want to wait on that. That needs immediate treatment. And if those things don't apply to you, if those 3 things don't apply to you, you have time. You have space. Take a breath. Learn. Educate yourself. Get in touch with yourself. Really think about these things and what you want and what feels right to you. And read my book. Assemble your team. Put people around you who hear you. You get a vote. You get a vote here. This is not a committee of one, and your doctor is not your dictator and shouldn't be. And so I think that what's right for each and every person is different. I'm not throwing the baby out with the bathwater. I'm not saying that we're not going to take anything from conventional medicine. There are lots of things in conventional medicine that I continue to use and continue to recommend. But I'm not doing all of the things, and I'm doing what's right for that person sitting in front of me. And there's only one me, but there are lots of people like me who are willing to sit with the person in front of them and hold space for them and honor their opinion, and at the same time be able to say from a clinical standpoint, I think this would help you. I think we need to work on this. I think we need to ask your why, because there's always a why, and it may not be one thing. So I don't know. Do you have mold in your home? Do you have metal amalgams in your mouth? Do you have root canals and chronic infections? Do you have trauma that's unresolved? Whatever it is, do you have some reason, something that's holding you back from your health? Because we're not meant to be sick, and our bodies are meant to heal.
So I got to back up a little bit when you were talking about overdiagnosis of breast cancer, and I'm paraphrasing. So are there people that get breast cancer treatments that don't truly need them, or that don't have true breast cancer? Can you expand on that?
Over 100,000 in this country every year alone.
Wow. So you're telling me, I just want to make this clear. You're telling me people are diagnosed with breast cancer and they are getting treatments like radiation, chemotherapy, and possibly surgery, and they don't really truly have breast cancer. Can you please give me the details?
Okay, so it depends what you mean by really truly have breast cancer. So let's start with the DCIS population, right? Ductal carcinoma in situ. Now, I do not believe that DCIS is cancer. I think that cancer by definition is something that is life-threatening, and DCIS by definition is not life-threatening. And no one dies of DCIS because DCIS has no ability to get into the bloodstream, to get into the lymphatic system, and to spread anywhere else in the body. And anyone can live without a breast or with DCIS in your breast. This is not a life-threatening disease. Yet, when you treat it, because oftentimes the treatments include surgery and radiation and anti-hormonal medications, and once you put radiation and anti-hormonal medications in the mix, this is no longer 100% survivable, because once you damage the heart, damage the lungs, damage the chest wall with radiation, there's a fatality risk associated with that, right? It accelerates heart disease. It makes you more likely to develop cardiomyopathy. So the cardiovascular disease rate is significantly increased, or you're on anti-hormonal treatment. Well, estrogen is very protective. So if you take away women's estrogen, then they're going to have cardiovascular disease, neurodegenerative disease, osteoporosis. And lest we forget, the same number of women that die of breast cancer every year also die of a complication of a fracture. So if we are treating one disease, but giving women a second equally or more lethal disease, how have we helped them? So there are 90,000 cases a year of DCIS diagnosed in this country, most of which undergo cancer treatment for that disease. And yet we know the data out of UCSF and Dr. Laura Esselman is that 80% of DCIS will not progress. 80%.
Janet.
So instead of working to figure out who does and who doesn't need treatment, we just treat everyone under the guise like, well, we want to protect that 20%. Really? Do we? Is that our motivation? We can't put some money towards a test to figure out who does and who doesn't need to be treated, because it makes a lot of sense, but doesn't make a lot of dollars.
Right. Well, we've also
And the breast cancer industry is $1 trillion industry.
Right.
Yep.
And we've also opened up the can of worms of the genetic part of it too, where, you know, I know people personally who've had mastectomies because they carry a certain gene. So what about that?
Like BRCA gene.
Mm-hmm.
Yeah. So we know that our genes are not our destiny, right? They're a suggestion. They're a roadmap, but as anyone who uses Waze frequently knows, there's lots of ways to get there, right? And so for people that have genetic mutations, this is the irony in it. These people are told to screen early and screen often. But by virtue of the fact that they have a genetic mutation, these mutations, these changes in the gene, these are our protective genes. These are our anti-cancer genes. So by definition, these women with BRCA mutations are women whose genes have already said, I can't handle environmental insults like radiation. So what happens when we screen them early and screen them often? We essentially guarantee that they develop the disease.
Right.
It is so crazy to me that this is what's happening, but then you know, unfortunately, it's a game of follow the money. That's all this is. So for people who are mutation carriers, they need to be even more cognizant of what they are encountering. They need to be more aware of what they eat and when they eat and how they eat and what they drink and how they move and how they sleep and how they detoxify. These are things that are extremely important. They need to be more vigilant about their environment, but what they don't want to do is do more screening. And Gilbert Welch, I don't know if you've ever interviewed him. He's a brilliant guy. And in 2014, he wrote the book Overdiagnosed. And he's not just talking about breast cancer. He's talking about a lot of the areas where we are overdiagnosed. The whole cholesterol story.
Damn.
Hypertension,
Yep.
Thyroid cancer, breast cancer, prostate cancer. I mean, you name it, depression, you name it. And you can trace this back to the motivations, which are we just continue to lower the threshold for what constitutes as a diagnosis so that we can give more and more treatment. But we're not getting healthier. Yep. We're not getting less disease, and we're not getting better outcomes. So what are we doing? Because in the end, this all needs to be about better outcomes. And we shouldn't be doing anything unless we're getting better outcomes.
That's so powerful and so true. I mean, we create a diagnosis. ADHD is another one. I mean, I think largely ADHD is just a created diagnosis. You know, it wasn't, 30 years ago in pharmacy
we should
school,
call it the feed your kids a lot of sugar and processed food, and you will have inattention disorder diagnosis.
Exactly.
That's what it should be.
So, Zoe, we have a comment. Let's see what that comment is. It might be a question for Dr. Jenn. Oh, yes. So, from
Can I quickly say one thing about invasive cancer, though? Because a lot of people say, oh, well, okay, fine, DCIS, maybe you consider that overdiagnosis, but there are women who are diagnosed with invasive cancer. How can you say that they don't have cancer? There is an autopsy study of women who died of not of breast cancer, but car accidents, suicides, overdoses, that kind of thing. And if you section through their breast, 1 in 5 women will have microscopic evidence of breast cancer. 1 in 5 women. Now, we're talking about 20-year-olds. 1 in 5 20-year-olds will have microscopic evidence of breast cancer. 1 in 5 20-year-olds do not have breast cancer. Nothing like it. Not even close. Right? So the fact that we are finding these microscopic findings because we're screening with these really unsophisticated tools, and we're then, giving people these diagnoses and treating them like they have clinical disease, and then setting them up for all of these diseases as a result of treatment, like heart disease, like neurodegenerative disease, like osteoporosis, like depression, like anxiety, things that really end up mattering and diminishing the duration and quality of their life. This is a big problem. And we're doing this in 20 to 30% of the women that we're treating for breast cancer. So let me just give you what those actual numbers look like, because in 2024 we diagnosed 300,000 women with breast cancer. It means that 60 to 90,000 women last year in the United States alone were unnecessarily treated for breast cancer. So I know all of these people out there saying mammogram saved my life. It found my cancer before I even felt it. And had I waited to feel it, I would have died of metastatic disease. That is the story that they would love you to believe.
Mm-hmm.
That is the story that many women believe. But owing all your gratitude to a mammogram that probably, statistically speaking, got it wrong and you were unnecessarily treated, I don't know. It's very hard to unring a bell, and I am trying. I mean, I am out there at every opportunity, but it's hard. And this system will not go down quietly. Again, $1 trillion industry. It's not going down quietly.
Yeah, exactly. So let's get to Deb Gravel. Deb, if you're still listening, if you're taking questions, when is a preventative mastectomy the right choice?
Right. So that answer is really easy. If you think that that's the right thing for you, that's the only time, because there is no survival advantage to prophylactic mastectomy. And in fact, when I first started in practice as a breast cancer surgeon, and bear in mind, I did it for nearly 20 years. When I first started, we were taught that in the BRCA mutation population, this population did benefit from prophylactic mastectomy in that we would save their lives by doing prophylactic mastectomy. They are no longer being offered prophylactic mastectomy. So the data no longer supports that. And that's in the BRCA mutation population, where if those women did nothing, they had somewhere between a 60 to 80% chance of developing breast cancer over their lifetime. And if it doesn't benefit from prophylactic mastectomy, I don't know who would. No one.
Well, and to me, I can't believe, I know people that have done the prophylactic mastectomy thing, and I just saw money written all over it. And they would do it based on, well, because you have the BRCA gene, your insurance will cover it. And they basically get a free boob job, essentially, because of this. And we were just destroying women. It never, ever made sense to me whatsoever.
Yeah. I mean, whether or not you have a reconstruction, I can tell you that if you have a mastectomy, if you have complete removal of your breast, there will never come a day for the rest of your life that you will not be reminded that you either had breast cancer or you were at high risk for breast cancer, because we are never, ever, and I don't care how talented you are, and I am a very talented surgeon. I don't care how talented you are. We can never do anything that even approaches what God gave us.
Nope, not even close. So talk about, is there any studies out there? Because mammograms, you know, they have radiation. They produce radiation.
Yeah.
Radiation causes cancer.
Yes.
Those are facts.
Yes.
Is there any studies out there to
How
show
dare
that?
you be so logical?
Yeah, right.
So the estimation is that 5% of breast cancers are radiation induced, caused by mammograms. We do know that the more mammograms you have over your life, the higher your risk is of being diagnosed with breast cancer. Just logical. I mean, the more radiation you have, the more likely you are to develop a disease. So there is a percentage of breast cancer that is directly attributed to having had mammograms. So there's two arguments that I get. First is, my breast cancer was detected on my first mammogram. Okay, so yours wasn't radiation induced, maybe. I don't know. Or maybe you've been keeping your phone in your bra for 20 years and it is radiation induced. I don't know. But the second argument, and the one that like makes me insane, and it often comes from radiologists, which is, well, the amount of radiation that you get during a mammogram is the same as you would get during a cross-country flight. And you wouldn't tell people not to fly cross-country, would you?
Right.
So I'm just going to briefly review the difference between the scattered radiation that you get on an airplane and the focused cone down radiation that you get to the vulnerable, compressed, traumatized tissues of the breast during a mammogram. And, you know, you would think that anyone could see and understand this, but when you think about the sun is probably the greatest collection of energy there is. And yet you can stand out in the sun's rays for hours and not burn up. But a laser has a fraction of the energy of the sun, a tiny, minuscule fraction of the energy of a sun. You can't stand in front of a laser for 10 seconds. You'll burn up after one, right? And somehow, if you ask a radiologist if radiation causes cancer, the answer is a resounding yes. And then you ask them if a mammogram causes cancer, and it's an absolute no. And it's just amazing to me. And it brings me back to that Upton Sinclair quote, which is, I might not get it exactly right, but it's something like this. It is impossible to teach a man something when his livelihood depends on him not knowing it. And that's what it comes down to. The radiologists will never see this as an issue because they can't see it, because it threatens every single thing that they do and believe in every single day.
Janet, you have a question?
I do. So throughout the years, you know, and I've even done this myself, I've done thermoscans. What is your thought about that? And then we've got all the other, like your MRIs and your ultrasounds.
Yeah.
And I mean, because we get those things thrown at us too.
Yeah. Yeah. Well, at the end, I am going to share with you that none of this matters anymore because there are 100% safe ways to accurately screen for breast cancer. But thermography, it's perfectly safe. I don't use it for breast cancer screening because I don't think it's reliable. I've known too many people, even with clinical disease, who have had negative thermography scans. And that's because thermography relies on inflammation and a heat signal. And most breast cancers are slow growing enough that they're not going to create a significant amount of inflammation or create enough of a heat signal. Now, maybe that means that those are the cancers that we don't need to treat.
Right.
I don't know. But because I can't rely on it, I don't use it. Do I use thermography for other things? Yes, for sure. When I'm looking for a source of inflammation, I know someone has inflammation and I can't find it, I'm using thermography because I think it's a great tool for that. But I'm not using it as a screening tool for breast cancer. I'm also not using MR as a screening tool for breast cancer. And this is because in order for the MRI to be of value, it needs gadolinium. Gadolinium is a heavy metal that is stored in our body. And there's two problems with that. First, it's always stored at the expense of something else. So it's going to lead to nutrient deficiency. The other thing is that when it is stored in the organs, the brain, the kidneys, it causes permanent damage. So I think that we're just on the brink of understanding how much damage we caused by deciding that MR was a good screening tool for women and we should do it every year. So I think we're just starting to see the damage that's been done by using that as a screening tool, but I do not use it because I don't believe in putting the screening population, right? These are healthy asymptomatic women. And I don't believe in putting healthy asymptomatic women in harm's way. I think it's unethical to do that. So what do I do for screening? First of all, I believe that every woman should be doing self-breast examination. Everyone thinks their breasts are lumpy. That's okay. Own your lumps, right? Know what your breasts feel like when they're normal so that you can know what they feel like when something has changed. The second thing is the ARIA test. This is the tears test. I don't know if you've heard of it, but it screens your tears, so the fluid in your eye, for two proteins, the S100A8 and S100A9 proteins. You may know these proteins as their dimer calprotectin. But when they are the isomers, the separate proteins, and they are raised to critical levels, it is highly predictive of breast cancer. It has a 93% sensitivity, so better than any other imaging other than MR, but MR has a very high false positive rate. And it has a 58% specificity. Now, some people say that that is too low because 42% of the time it will be positive in someone that doesn't have breast cancer. So there's two things I want to say about that. First, it's compared to a mammogram, and a mammogram specificity is not good, or their sensitivity isn't good. So a mammogram is going to miss 40% of cancers in the dense breasted population, which is 40% of the population. So it's compared to a test that is not good at detecting cancer. So I believe that the inherent specificity is higher for ARIA. But the second part is that I say to people about the ARIA test is that there is no such thing as a false positive result, in that you either have the inflammatory precursors to breast cancer or you don't. And if you have the inflammatory precursors to breast cancer, if this ARIA test is clinically positive, you are at increased risk of developing breast cancer. And what this is opportunity. This is the opportunity to prevent a diagnosis, to do what you need to do to mitigate that inflammation and prevent a diagnosis. So I'm doing the ARIA test on everyone. And as far as imaging is concerned, if we're talking about the screening population, again, asymptomatic, have no reason to believe that they have breast cancer, I'm using the QT scan like what we have at Perfection Imaging, or you can do an ultrasound. But I don't think that you should ever be using a test that causes cancer to screen for cancer. I don't think that we should ever be using a test where we have to give someone a heavy metal in order to interpret that test. And an MR without gadolinium is useless. And I think that when you combine physical examination, the ARIA test, and QT or an ultrasound, you don't have to worry about what you're missing because it is insignificant. I don't believe in chasing subclinical disease. It doesn't improve survival. It doesn't improve quality of life. And I think it's the wrong thing to do. And so in my practice, that's how we're screening for breast cancer. And I am not chasing subclinical disease.
I love that comment right there, Dr. Jenn, because as you know, we chase subclinical diseases all the time. People aren't sick at all yet. Well, your glucose, your cholesterol's 201. We got to give you a statin. Your blood glucose is 101. You're pre-diabetic. We got to put you on metformin. We do it all the time.
Well, we as medical professionals are very useful idiots. We really are. And we're just getting people into the system. And with each medication that we put them on, we're keeping them in the system because as you very well know, if you put someone on a statin, you increase their risk of metabolic disease by 63%.
Right.
So then you can get them on the metformin and eventually insulin. And you will probably also give them hypertension as well. So then you can put them on beta blockers and ACE inhibitors and hydrochlorothiazide. And from there, they will have more and more and more dysfunction. And also, they'll be depressed. So you put them on an antidepressant. And I mean, you know how this goes.
We do. In fact, here's the thing I think that we aren't good about. We're not sharing the prevention part, that people can take the responsibility for their own body and be able to prevent things. So the wellness part of it, that is something that's always lacking, other than go get your tests, right? Like screen and do your tests, but
that's not really prevention, right?
No.
That's your entree into the system.
Exactly.
Yeah. And for most people, like if you're someone who thinks you're doing the right thing and you're going to get your yearly screenings, and let's say you come back with a hemoglobin A1C of 5.7, what happens to you? You get told, I'll see you next year. And next year it's 5.8. I'll see you next year. Next year it's 5.9. I'll see you next year. It's 6. Okay, now we're ready to medicate you.
Yeah, right.
But there's no are you eating a whole food diet? Are you managing your stress? Are you meditating? Are you moving your body? Are you prioritizing sleep? Like, where that conversation isn't happening. It's not happening at all. So of course, that person is just going to continue to progress, because without change, how do you change? And the definition of insanity is doing the same thing and expecting a different outcome. But the system inherently, I mean, I don't think doctors are bad, believe me. Like, I know everyone goes, and providers, I'll use providers. I know everyone goes into it with the best of intentions. Although, what's that saying? The road to hell is paved with good intentions.
That's right.
I think that everyone goes into it with the best of intentions, but getting into the system requires critical thinking. Staying in the system requires that you stop thinking and just follow. And most physicians, and certainly I was in this boat myself, you pay a lot of money and you spend a lot of time to get that degree and to get your position and to become that doctor that you want to be. And you get there, and then you have to build a practice. So that's 5 years. So 5 years with your head down, working, not thinking about what you're doing, because you're doing what you were taught to do, right? Like, the best medical oncologist is the person that does exactly what they were taught to do. Right? But we have completely lost sight of what it means to be a good doctor, a good nurse, a good provider. We've completely lost sight of those words that we say the first day that we put our white coat on. First, do no harm. We've completely lost sight of that. And we inherently trust that what we were taught is true and right and good. And unfortunately, for most of what I was taught, none of those things are true.
It's interesting. We are. And I got to, Zoe, go ahead and put the QR code on the screen. I got to do a shameless plug for my book I'm writing. You'll get a kick out of this. And go ahead and screen show the graphic down at the bottom, Zoe. So I'm writing a book, Dr. Jenn, Lies I Learned in Pharmacy School.
Oh, I love that title.
Yeah. And how to escape the grasp of big pharma. So many things that you talked about today are just right up that alley. And I'm right. I have a section in there on cancer. And let's not forget too that not only do mammograms cause cancer, those are just facts because it's radiation, but the treatments that we
no need to get your panties in a bunch. It's just facts.
And here's the second fact. The treatment we give for breast cancer with radiation causes cancer. Those are facts. And any oncologist that wants to argue that, they are lying. They're lying. They're not ignorant. They're lying. Those are just facts. So you can go ahead and share that. I do want to get in your book as we finish this up. So Smart Women's Guide to, we're streaming on Amazon there. Smart Women's Guide to Breast Cancer. Tell us a little bit more about your book and why people should buy it.
Yeah. So I originally wrote the book so that women who were faced with a breast cancer diagnosis could make an educated decision, because they're not given that opportunity now. And they're so scared, and they don't know what questions to ask, and they don't know what the right answers are. And so that is the first part of the book, is just giving you the questions you should be asking your surgeon and asking your medical oncologist and your radiation oncologist, but also what to ask your integrative oncologist and your reconstructive surgeon. And then how to understand your pathology report. What do all these things mean? But the bulk of the book is, okay, what are the other things that you can do for yourself? Because we can't farm out our care to people who don't deserve to be in charge of it. And quite frankly, your surgeon doesn't know how to make you healthy. Your medical oncologist for sure doesn't know how to make you healthy. Your radiation doctor doesn't know how to make you healthy. I hope your integrative oncologist does. But in case they are just someone who is saying, have acupuncture too, or, do this supportive care. Everyone who gets a cancer diagnosis gets a treatment plan, but what everyone needs is a health plan. And inside of this book is your health plan. Now, as it turns out, there's as much prevention in here as there is treatment. Because the truth is that whether you've had a breast cancer diagnosis or not, everyone needs prevention, because you want to prevent a recurrence and you want to prevent having it in the first place. So I wrote this book for the woman that has breast cancer, but I also wrote it for her sister who doesn't, for her mother who doesn't, for her daughter who doesn't, for her neighbor who doesn't, for her best friend who doesn't, because I never want another woman to suffer unnecessarily.
Wow. What a wealth of information you are, Dr. Jenn. I so appreciate you coming on our podcast today. There's so much to unpack. We could keep talking for hours. I'm sure Jen and I are both pharmacists that, don't believe in drugs to treat most long-term disease. However, we do specialize in hormones. And I'm sure you have a big opinion on bioidentical hormones. So maybe we can have you back on sometime.
I would love to come back on
and talk about that. We will.
But just to let you know, I'm a huge fan.
Yeah, I figured you were.
Yeah.
And so we will schedule you to be back on. And if anybody has any questions as we wrap this up, Dr. Jenn, I want to. What's the best way to get a hold of you?
So you can go to any of my social media channels. I'm at Dr. Jenn Simmons on everything, and just make sure my Jen has 2 N's. And then my website for women that have breast cancer is Real Health MD. And for anyone who's looking for safe, painless, radiation-free, dye-free breast cancer screening, that's my imaging company, Perfection Imaging, and Perfection is spelled with QT in the middle.
Awesome. I love following you on social media, and I really recommend anybody that wants more information, follow Dr. Jenn on Instagram. I think that's where I found out about her, and just a lot of great information, answers questions, but also, one thing I like about it too, Jenn, is even after today's podcast, I have more questions now than I ever did. And I think that's a good thing. As healthcare professionals, we need to keep questioning what we're doing, because like you said, what we've been doing is insanity. What we've been doing for breast cancer, cardiovascular disease, diabetes is not working.
No,
we need to do something different.
It's the opposite of not working.
Right.
We're creating more disease.
Exactly. And I think that's by design, but that's another episode in itself.
Yeah. Well, I'm happy to come back. I'd love to do it again. And for anyone who wants to hear more from me, I do have a podcast every week. I know that you guys are coming on. It's called Keeping Abreast with Dr. Jenn, and we release a new episode every week, and you can get that anywhere that you listen to your podcasts.
I love it. Thank you so much, Dr. Jenn. We
you.
really appreciate you. We're looking forward to talking to you again. Listeners and viewers, thank you for tuning in to Health Solutions with Shawn and Janet Needham. Tune in Wednesday to our midweek podcast, 8 a.m. to 9 a.m. Pacific Standard Time.